recording. That's fine. Okay, so we're going to pick up with the peripheral nervous system today. And when we talk about the peripheral nervous system, if we fill in our flow chart here, we have the central nervous system, which is in gray. We've spent a lot of time talking about the central nervous system, talking about the motor tracks going up and down. We talked about how to generate an action potential and how graded potentials lead to action potentials. And then now in this topic, we're going to talk about transmission to and from effector cells. So this is the peripheral nervous system, and we have the sensory pathway bringing information from sensory receptors to nerves, spinal nerves or cranial nerves, right? That's what makes up the peripheral nervous system. How many pairs of spinal nerves? 31, and cranial nerves? 12. So we have sensory information coming in from those nerves via what route in the spinal nerve? Yep, via the dorsal root. And then the motor information comes out through those nerves via which route? Ventral root. Okay, so this is sensory. And what do we call that pathway bringing information out of the central nervous system? Efferent or motor. Okay. So this would be motor efferent pathway. And that response, the motor response, can be voluntary or involuntary. What do we call the voluntary response? Dealing with skeletal muscle. Somatic, so that would go here. And then the involuntary, dealing with cardiac muscle, smooth muscle, and glands. Autonomic, so that's what goes here. And then the two branches of the autonomic nervous system. Parasympathetic, sympathetic. Now we've looked at this one several times in this note packet, but it's one of those that we need to constantly review to remind ourselves how this how this nervous system is organized. And I would recommend cutting this out of your PowerPoint if you do like 6 slides per page even, and then just cut this out, put it in your pocket, and it'd be a little thing maybe to take to work, or if you're just sitting around, pull it out, look at the details, test your understanding of it, because a lot of good information here, and I could generate actually quite a few test questions off of it. Doesn't seem very power-packed, but it really is, because it organizes the whole nervous system for you. And you can go into detail in each of the boxes. So the more detail you can give for each of those boxes, the better your understanding and the better you're going to do on our upcoming exam. Okay, so looking at, this is on, or in chapter 13 we're in, and figure 13.6 just talks about the different segments of the spinal cord. So it's different than the vertebrae or the spinal column, the bony structure that surrounds the spinal cord. So we have the nerves of the cervical region, and there are 8 of those. So there's C1 through C8 here in the neck. And an important nerve that comes off of that is the phrenic nerve, which serves the diaphragm. So people that have a cervical spinal cord injury will lose the ability to contract the diaphragm and breathe. So very often they're on a ventilator to stimulate that diaphragm to breathe, to allow them to breathe. Then we have the thoracic region of the spinal cord, which is T1 to T12. Then we have the lumbar region of the spinal cord, L1 to L5 nerves. And then the sacral region of the spinal cord is S1 to S5. And then lastly, we have one coccygeal nerve. So they don't come off at this level. They actually come off of here and branch all the way down. So the spinal cord itself, you'll see, ends right about here. You could just put CO1 as an abbreviation. That's how we abbreviate it, CO1. But if you wanted to be fancy, it's COCCYGEAL. I feel like I'm back in my spelling bees in middle school. I actually went to the final 15 at the high school back in middle school on spelling. And you know what I got wrong? It was earring. Because I thought, oh, you know, it sounds like it would have 2 R's, but it must be, and I was thinking it must be 1 R because I'm in the final you know, it must be what you would think it's not. So I put 1R. Oh, so mad. Yeah. Because there are a lot harder words to get to that point, you know, and it wasn't meant to be. Anyway, so the spinal cord ends, you know, right at the beginning of the lumbar region. So, you know, right just below the ribs is where the rib cage, right about here, is where your spinal cord ends. And then the nerves branch off in this long tail-like structure, which is called the cauda equina. Some people, well, not some people, anybody can translate that to horse's tail. So those nerves, you know, extend quite a bit here beyond the spinal cord. But you don't have to know cauda equina. That's more of an anatomy term. Just so you understand that there's 5 different sections or different types of spinal nerves and how many. And a good way to remember that is we have breakfast. Typical day for a person that works maybe 9 to 5 would be, or 9 to 6 would be breakfast at 8, lunch at noon, and dinner at 5. What? Oh, I'm sorry. Sorry. Yep. No, there's 8. See 1 through 8. Did I say 7?
No, that's what we're.
Oh, you were thinking of the vertebrae. See, the spinal cord's a little different. Yeah. Right. Yeah. This is the spinal cord. These are the spinal nerves. You're thinking of the spine, the vertebrae. So 8, noon, and 5, and then 1 at the bottom. Okay. Our next slide is from your textbook on page 488, and it talks about the different levels of integration when we're looking at sensory information. So these are all sensory receptors. So this box at the bottom is the receptor level of a sensory system. So we're stimulating a receptor. And what type of receptors do we see here in the skin? What type of, I mean, sensory, yeah, what type of sensory receptors? What would they be sensitive to? Because think of our ascending pathways. Touch, temperature, pain, pressure. Yep, good. So those types of receptors are stimulated down here in our receptors in the skin. And then in the muscle, we have 2 types of receptors. This is the muscle spindle, which we're going to talk about today, and then there are special muscles or special receptors in the joints that are called kinesthetic receptors, but you don't need to know that. Just know that these 2 are examples of receptors that help with body position. And what do we call those receptors? That's the very good. Proprioceptors deal with body position. So just you can classify those 2 together as proprioceptors. So we have information that we can be consciously aware of, and some we're not so consciously aware of, right? We have subconscious proprioception and we have conscious proprioception, depending on the motor tract, right? And remember, the spinocerebellar tract was the subconscious proprioception, so we can see this neuron going right to the cerebellum. How many neurons are there in a sensory system, typically outside of the spinocerebellar? 3. We have the first order neuron, right? So that's what these are. These are all first order neurons. And then we have second order neurons, right, that go to the thalamus. And then third order neurons that go where? Yes, very good, the somatosensory cortex. Okay, so we have the receptor level here. Number 2 is called the circuit level. And this is where our motor tracts are, where we're taking the information. It's just the axons of that first order neuron that are projecting to either the cerebellum or the thalamus. That's the circuit level. And then up here we have the perceptual level. Number 3, the blue box, is the perceptual level. That's where we, in the cortex, can say, this is soft, this is painful, this is hot, this is cold, this is a heavy pressure, light pressure, tickle. All that sensation occurs here in the somatosensory cortex. So this is the perceptual level. Remember, action potentials are in the second and third order neurons. So where does that action potential have to begin then? What leads to, well, let me pedal back a minute. What leads to an action potential? A graded potential, right? Because we're starting out at -70. We need to get to what to get an action potential? Threshold, which is -55, correct. So we need to get to -55. So where is that occurring? Where are graded potentials occurring in this diagram? Graded potentials, right, in number 1, down here. This is where the graded potentials are occurring, down in these dendrites, right? And then, where is the action potential generated? In the axon hillock of which order neuron again? How does it get from the sensory receptor to the axon and down to the second order neuron? Here's the second order neuron. How does it, so this is all traveling up the spinal cord, isn't it? Graded potentials travel up axons? Action potentials do. So where is the action potential generated? In any neuron? I think axon hillock. So axon hillock where? In the first order neuron. Yes, in the first order neuron. So the graded potentials begin in the dendrites, in the receptors, right? In the sensory receptor is where those dendrites are. So that's where the graded potentials begin. So we need enough stimulus at these sensory receptors to get enough graded potentials to reach the axon hillock, right, at -55 of that sensory receptor neuron, the first order neuron. Once we reach -55 at the axon hillock of the first order neuron, we fire off an action potential and off it goes to the second and third. Make sense? Correct. We have to generate an action potential in that first order neuron in order for it to make it to the brain. It's like the horse race we said. Once you get that action potential, off it goes. Okay, and we're going to talk, I think it'll make more sense when we get to the next unit on the autonomic nervous system to remind ourselves how we get an action potential from one to the next. Okay, so those are the 3 levels. What can happen down here in the receptor level is a special concept called adaptation. Is if you have constant stimulus, what happens is these sensory receptors can adapt and no longer respond, which means no longer generate an action potential. So if you have constant pressure, say, or temperature, well, that temperature to a certain degree, you tend to not perceive that anymore because action potentials are not generated. They adapt to constant stimulation. But what do you think, what type of receptor never adapts? Because if it did, we'd kind of be in trouble. Yeah, pain. And what kind of receptors are pain receptors? What's the name of those again? Because that would be on the test. Yeah, nociceptors. Nociceptors, N-O-C-I-C-E-P-T-O-R-S, nociceptors. Those do not adapt because we don't want to adapt to pain. Pain is telling us that something's wrong. But the bad part about that is that we constantly have to treat pain. And people can be, they can adapt to medications where the medications don't work anymore. Now you have to switch the medication strength or type to deal with that pain. And nerve pain is an especially difficult pain to treat just because the nature of that pain is different than other types of pain. So anyway, we have this adaptation that occurs. Yes? Yeah, pain tolerance is different than pain threshold where we feel pain. That doesn't necessarily vary among people, but how we perceive pain, a lot of it depends on genetics. A lot of it depends on experiences. And they think there's a psychological aspect to that as well because you have those patients, right? You ask, what is your pain level right now? Oh, it's a 9. And they're chatting on the phone and eating their dinner. You know, that's not typical to say that that's a 9, right? Or you have a person say, yeah, oh, I'm not in too much pain, and then you look and their arm is broken. And you're wondering, oh, you're not in pain and you have a broken arm all the way broken through the shaft of the bone? So some people just, yeah, it's genetic, some of it, and they don't really know why one person has a higher pain tolerance than others. And it doesn't mean, though, that we need to ignore those people that, you know, say that something's really hurting. Like you get a patient that comes back from surgery, And typically a patient like a appendicitis, for example, let's say someone's coming back from an appendectomy, and they're saying, oh my gosh, this pain is so terrible, this pain is so terrible. And then you have another person that comes back, and it's just a laparoscopic, very minor surgery. Another person comes back, and they're ready to get up and go back to work for the afternoon once their medicines wear off. Of course, that wouldn't be realistic to do that, but they feel good enough to do that. What's the difference between those two people? One person's faking it and being a crybaby, another one isn't. No, we all have different innervations too, and when you do surgery, sometimes we involve nerves that everybody's, the branches, the fine branches of their nerves involving organs can differ from one person to the next. So they can have very different types of pain from the same surgery. So we never want to underestimate people's pain when they report it as high. Everybody has a right to pain medication if they've had surgery, and there's reasonable expectation for some pain. Even a person that's addicted to narcotic pain meds, do they deserve not to get extra dosing on their pain meds if they've had surgery? Of course not. They deserve, again, pain control just like anybody else. Even though they might need 3 times the dose to get there, they still had an injury or a surgery, and it's our job to make sure that they're covered and not judge them and say, oh, you've had too much. But then you do have the pain medicine seekers, the drug seekers, and you have to be aware of that. But that's a small percentage of patients. That's not a majority. So we have to really, keep our awareness of that. So anyway, you need to also remember that what is going to determine increased pain versus less pain? The strength of stimulus coming in, for one. So the strength of the stimulus, what does that do for action potentials? More action potentials. So increasing stimulus strength means more action potentials. So stronger pain sensations, it means more action potentials at that neuron, in the first order neuron. Okay, so moving on then, looking at our next, slide, this is on page 512. This is looking at levels of motor control. So we looked at kind of levels of sensory information coming in. Now, how do we control what goes out from the brain? So at the very bottom, this is the segmental level of motor control. So that means you're looking at that specific segment of the spinal cord and the nerves that branch off of it. So what do we know happens at the spinal cord level where we can have motor output going out to muscles, out to skeletal muscles? At the level of the spinal cord, what do we call that? It involves an interneuron. A reflex, yeah. So reflex activity is happening down here. This is the segmental level. That's what we call this, is the segmental level. This is like, again, on your textbook on page 512. So reflex activity is down here. And you can see that here. Can't you see the sensory? Throughout this book, sensory is given a blue arrow and boxes. So this is sensory information coming in and motor information going right back out, not ascending to the brain. So this is reflex activity down here in the segmental. And anything that involves automatic movements, like when you're walking, swinging your arms, that's not a lot of higher brain control. That's just automatic movements that happen at the level of the spinal cord. So that's segmental. Then the next level up, this is where we have the motor tracts. So this is specific control via motor tracts. So voluntary, the pyramidal motor tract is what we can voluntarily move when we want to, write with our pencil, pick up a book, kick a soccer ball. That's happening here at this middle level called the projection level. So the projection level, motor tracts. The brain stem has a little bit of control there also when we're talking about control of basic movement. So again, this is the projection level. But fine movement, fine, skilled, precise movement needs a little more control, and that happens up here, which is subconscious, beyond our conscious control, at the very top, and this is called the pre-command level. This involves the cerebellum and the basal nuclei. So people with Parkinson's disease have damage to the basal nuclei, which lie in pyramids just outside the thalamus, which doesn't give that inhibitory response to these motor tracts, and you end up with excess movement. And if you look at a person with Parkinson's that's off their medication, sometimes they have to take vacation holidays because their medication doesn't work anymore, so they have to take them completely off for a while and then put them back on. Well, if you see them at that point, they're just moving around. Their entire body is moving constantly. And that's because they've lost this pre-command level that helps send what type of graded potentials would it send to control this pyramidal motor tract? IPSPs, right. It inhibits. So at this level, they're sending inhibitory information to control this level and this level as well. Because if we control this, we can control this. It's the neurons. It's gradual destruction of those neurons that respond to dopamine that causes an inhibitory potential in those neurons. Yep, yep. All right, so questions on that? So when you look at this pre-command center, what it's really focusing in on is muscle tone, if you're looking at the subconscious level of things beyond our control. So muscle tone and fine skilled movements. And stopping and starting movements. And that's what people with Parkinson's have trouble with. They have this shuffling gait as they're walking because they have a hard time initiating that movement of the foot forward to get walking. So it's a conscious effort to get those legs moving forward. And as a result, they tend to fall more easily. I've had friends that have had relatives that are newly diagnosed with Parkinson's, and oftentimes one of the first things they notice is tripping and falling. Happens more easily. And that's because they're of the damage to at the pre-command level. All right, we've talked about the reflex arc, so I'm not going to go through these all again, but we're going to examine this reflex arc in a little bit more detail. And that's looking at how our muscles maintain their tone and keep us upright. And a really important structure involved in keeping our muscles allowing us to stand upright and in a subconscious way is what's called the muscle spindle and the Golgi tendon organ. So this whole structure here, all of this is the muscle spindle. And down here is the Golgi tendon. And what the muscle spindle controls, it's buried in the belly of the muscle, or deep in the muscle I should say. The muscle spindle controls and monitors the length of the muscle. So if it's stretched or contracted. So it controls the length of the muscle. And the Golgi tendon organ helps control the tension in the muscle. So think of tendon, tension, and spindle has an L in it, and ends with LE, and that controls the length of the muscle. So two different structures involved with, again, this would have to deal with body position, keeping us upright, keeping our muscles contracted to maintain a standing position, for example. Now, in your worksheet packet, there's a really nice diagram of the muscle spindle. It's on page 330. So I'm going to keep this diagram up because I can't record and project on the dot cam. It just goes blank on the screen. So this whole structure here, in the worksheet packet, page 330 of your worksheet packet, what number is indicated by this whole structure here? Number 5. So number 5 on that packet is the muscle spindle. within the muscle spindle are these special fibers here that are wrapped with a neuron, which is called the alpha motor neuron. No, that's wrong. I'm sorry. No, I'm sorry. That's a special sensory receptor. Remember, it's blue. It's blue. The red one is the alpha motor neuron. We'll talk about that in a minute. But this is the one that actually synapses on the muscle fibers of the whole muscle. This is the alpha motor neuron. Because red is motor, blue is sensory. So this is a sensory neuron. So if you look at the diagram, which one is referring to the sensory neuron? Which means primary sensory endings in your worksheet packet? Number 1. Yep, number 1 in your packet is the sensory neuron. So this is, what is it detecting again? This is the muscle spindle. So what is it looking for? Length. The length of these special fibers. And these special fibers are called intrafusal fibers. So intrafusal fibers. What number in the diagram is referring to intrafusal fibers? Number 6. They're kind of ugly in the diagram. They look much better in this diagram. So you might want to label both as we're working here. So number 6 are the intrafusal fibers. These are the special fibers inside the muscle spindle that when they are longer than normal, that's going to fire an action potential in this special sensory neuron here that wraps around the middle of these intrafusal fibers. So the middle section of these intrafusal fibers do not contract. They are wrapped with this sensory neuron. But there are special neurons here at the end of the intrafusal fibers, and I don't think those are on your diagram. They're not. But these are, and you should label them on this diagram at least. These are called gamma motor neurons. The pink ones actually, the pink ones. Yeah, they split into 2. Those are the gamma motor neurons. So they maintain a little tension in those intrafusal fibers. So when I tap on the patellar tendon of the quadriceps muscle, comes down and attaches to, goes over the patella and attaches to the top of the leg, to the tibia, right? So when I tap on that tendon, that causes a stretch in the intrafusal fibers. So let's kind of label what's going on here. So when I tap on the patellar tendon, that's what's happening at number 1. And this is in your textbook also. Figure 1317. I don't have a page number, but quick find one here for you. This is on page 516. So when I tap on this, that causes an increased length of the intrafusal fibers and will fire an action potential in those special sensory receptors wrapped around the intrafusal fibers. So when I tap on that patellar tendon, it stretches this, makes it longer, which will fire an action potential in these, if I tap it hard enough, right, will fire an action potential in the sensory neuron, bringing that information into the spinal cord. So number 2 is just an action potential going to the dorsal horn of the spinal cord. And that action potential causes an action potential in the motor neuron. And this is a special motor neuron. It's called the alpha motor neuron. And that would be number 3A, correct. 3B is an inhibitory potential generated in the motor neuron that serves the hamstring muscles, because if I want to kick the leg out, I have to contract the quadriceps, but I have to relax the hamstring. So I need to inhibit the hamstring in order to get the quadriceps to contract. So this is an inhibitory potential in the motor neuron leading to the hamstring. So looking at this diagram, here is the alpha motor neuron stimulating the muscles cells, the contracting muscle cells outside of the muscle spindle. We call these extrafusal fibers because they're the major muscles that make up, say, if we're looking at the quadriceps on the front of the thigh, that's what keeps us upright. Because if you're standing there and your knees start to buckle, what happens to the length of those intrafusal fibers as the legs start to bend forward? Stretches. And that causes this reflex to kick in to contract those quadriceps a little bit to keep you upright. So this stretch reflex is not just for tapping the tendon to assess the pathway for nerve function, it's also important for standing. Because if you didn't have this constant input coming into the spinal cord, you're not going to be able to stand. So this is this muscle spindle is important for body position. That's why we said this is a proprioceptor, because it's constantly sending signals to detect the stretch in these intrafusal fibers and reflexively contract the muscles to keep that at the appropriate length. Questions on that? So what this does, oops, go back up. Okay, the Golgi tendon, your textbook doesn't talk a lot about the Golgi tendon, but that looks at tension in the muscle. And this prevents tearing of a muscle. If there's too much tension in the muscle, that's going to relax the muscle and prevent it from receiving an action potential to continue increasing tension. So it prevents tearing. So that's when you're lifting a really, really heavy weight and then all of a sudden you just can't and the muscle relaxes and you drop the weight. That's a result of the Golgi tendon organ, preventing too much tension from developing. So we have a limit to how much we can recruit muscle cell fibers to an activity, like lifting extremely heavy weights. So again, muscle spindles determine length of the muscle. They're going to contract, or they have a sensory receptor around their center, which will send information through the spinal cord to reflexively contract the extrafusal fibers and keep that muscle contracting to keep you upright. Questions on that? Let's finish the packet then, labeling the different parts. So the alpha motor neuron, did we give that a number already? That's number 2. And in the diagram, that's the red one. Spinal cord, that's pretty easy. What number spinal cord? 4, correct. Synapse. We have information going from the sensory neuron to the motor neuron. That happens at 3. Muscle spindle, we already said was 5. Skeletal muscle / extrafusal fibers, 9. And the motor ending to the extrafusal fiber, 10. Intrafusal fiber, we already said, was number 6. Receptor capsule, this means it's this, what's on here, number 7. And number are the ascending fibers. I mean, you're also going to know you're going to be aware of that contraction if you think about it. And what is that? Number 8. And that's conscious proprioception, going up that ascending motor tract. Okay, so now we're going to move into the autonomic nervous system. So autonomic nervous system is opposite the somatic nervous system. What 3 things are we focusing on as the effector organ in the autonomic nervous system? No, 3 different, yeah, cardiac muscle, smooth muscle, and glands. Okay, so when you look at the different divisions, parasympathetic, sympathetic, we'll call this the sympathetic, call this one the parasympathetic. So what is the sympathetic nervous system? What can we say about that? Fight or flight. So it's like, for most body systems, it's putting your foot on the gas, revving things up for activity. So if you're in a constant state of stress, Maybe you're not fighting or flighting, but you're just in a bad relationship or stress at work, stress in school. You're activating your sympathetic nervous system. So if you think about the effects of the sympathetic nervous system system-wide, chronic mental stress can really do its damage on the body, suppressing the immune system, increasing the heart rate, increasing blood pressure, slowing digestion. So you have people with high amounts of acid in their stomach, leading to ulcers, constipation, or diarrhea if they have an overactive bowel due to stress. So lots of effects of that. Parasympathetic nervous system, rest and digest. So that's where we're resting the body, so heart rate goes down, respiratory rate decreases, pupils constrict, the bladder contracts, so smooth muscle contracts, so bladder contracts, digestive organs contract. So we're going to get real detailed now in looking at the differences between the somatic nervous system, which is shown here. So you want to label this brown square here somatic, and this yellow one is autonomic. And this is a great diagram. There's a lot of power-packed information here. This is the parasympathetic, so you can put PNS here for parasympathetic, and then you can do SNS for sympathetic, or however you want to abbreviate it. And there's a nice worksheet that leads us to some good information about comparing the differences between these two. And let's look at page 340 in your worksheet packet. If we want to compare, we're going to put S for somatic, A for autonomic. So these are all autonomic. This is somatic. So remember, the effector is skeletal muscle here for the somatic nervous system. And for the parasympathetic, or for the autonomic, it's smooth muscle, cardiac muscle, and glands. So looking at number one, has efferent motor fibers. Is there a response? Are there motor fibers leading to skeletal muscle? Yeah. Are there motor fibers leading to these glands and smooth muscle? Do we have a response? If we have stress, does the nervous system send signals to our organs to respond to that stress? Let's look here. Here's the motor pathway, right? Sensory and motor. Does this box connect to the autonomic nervous system? Definitely. We definitely have a response. If I shine a light in your eye, does smooth muscle respond? It constricts, right? Yeah, so definitely there's a motor pathway to our organs. So the number one would be S and A. We definitely have motor response. This is pretty much showing the motor response, isn't it? Because this is this brown area, all of this is the central nervous system. Out here in the white, this is the peripheral nervous system. So this is a spinal or cranial nerve out here. So this is the central nervous system where the cell bodies are located. So a single pathway goes from the central nervous system to the effector cell. That means one neuron going from the central nervous system out here to the effector organs. Which one has that? Just the somatic. Yep, one cell, or one neuron, one axon. Because these have two, don't they? This one has two, this one has two, so only the somatic has one neuron. And what do we call this neuron here? Upper or lower? It's going from the spinal cord to the muscle, lower motor neuron. That's what this one is. Slower conduction of nerve impulses. How do we know which is the slowest? What determines speed of conduction? Say it again. Myelination on the neuron, on the axon specifically. Only the axon is myelinated. Which one has a myelinated axon the whole way through? Somatic. So slower conduction of nerve impulses for number 3 would be autonomic, because here we see to unmyelinated axons, and here we see it going to the blood. What do we know about the endocrine system? Is that a fast or slow? Slow. So definitely somatic is going to be faster. So autonomic has slower conduction of nerve impulses. Motor neuron cell bodies are located in the central nervous system. Here's the cell bodies. What would you say? All of them. All of them have cell bodies in the central nervous system. Typically thick, heavily myelinated motor fibers. Somatic, definitely. This is another one of those power-packed PowerPoint slides that you might want to cut out, label, study it really well. Lot of information here. I could generate probably 30 questions just from this diagram. Looking at organization, and then we're going to learn more about what these circles and triangles mean too. Okay, target organs are skeletal muscles, number 6. Somatic, we can see that here. Has preganglionic and postganglionic neurons. Autonomic. So here's the preganglionic, here's the postganglionic. This one is a special exception because it goes to the adrenal medulla, but here's preganglionic, postganglionic. Effectors are glands and involuntary muscles. Autonomic. Pathways are found in cranial and spinal nerves. What? Both, yeah, definitely. And here's an example. A cranial nerve that involves dilation of the pupil. Would that be autonomic or somatic? Autonomic, because the pupil is smooth muscle, right? How about if I turn my eyes side to side and up and down? Somatic, why is that? Right, under voluntary control. That's skeletal muscle on the outside of the eye that allows us to move, and those are both cranial nerves that control that, right? So those are autonomic and somatic. Number 10, one ganglion of each motor unit is located outside the central nervous system. A ganglion is a collection of cell bodies. Do we see any cell bodies outside the central nervous system here in the somatic? Do we see any cell bodies out here in the autonomic? Yes. This would be a ganglion. This would be a ganglion. So this circle right here is a ganglion. This circle here is a ganglion. Just because they show one neuron, there's actually many neurons involved in each of these. But we're looking at differences here. So this is a ganglion. This is a ganglion. Make sure you label those. Typically thin fibers with little or no myelination. Autonomic. You can see there is some myelination here, but not quite as thick and robust as we see in the somatic motor neuron. Effect on the neurotransmitter is always excitatory, which means if I stimulate, if I have acetylcholine released at the neuromuscular junction, that's going to cause an action potential in the muscle. And what does the muscle always do when you generate an action potential there? It contracts. And we're going to find that sometimes some of these will inhibit. For example, if I release acetylcholine from a sympathetic fiber, what is that going to do to the digestive tract? Do we want to digest while we're fighting or flighting? No. Slows it down. So that is not always excitatory. So only in the somatic is this release of acetylcholine going to excite skeletal muscles. All right. Then we have on the next page, number 13, neurotransmitter at the effector is always acetylcholine. So the blue triangles represent acetylcholine. So here's our effector cells. Which is always the blue triangles? It's only somatic, right? Because autonomic, here I see blue circles. Must be some other neurotransmitter here. So somatic is always acetylcholine. No ganglia are present, which means these clusters of cell bodies outside the central nervous system. Somatic, no ganglia here, just heavily myelinated axons. So the neurotransmitter effect might be excitation or inhibition. Autonomic. We might speed up or slow down the heart. Motor activities are under control of higher brain centers. Can we think about something that can cause our heart rate to increase? Yeah. Can I think about moving my skeletal muscles? Yeah. So what would we say then? Both. Yep. Okay, number 2 on the bottom has a lot of what we're seeing right here. So you're going to color code that, so that's something that you can do on your own, and you should be able to definitely do on your own. So I'm going to let you do that. Same thing with the next page. After we talk a little bit more about the autonomic nervous system, page 343, you should not have any trouble doing that one. And everything from here on out should all be within your ability to complete on your own. So let's talk about the difference between the parasympathetic and the sympathetic nervous system, those neurons. So when you, yes. Number 2 in the packet. You could get that information here from this one. Yep. Okay, so this one, the last part of number 2, which is on page 343, you can use this diagram. This has good information. So when we look at the parasympathetic nervous system, that's what's shown in purple here. These are all neurons that are part of the parasympathetic nervous system. So I would write information here. What are the differences between the parasympathetic and the sympathetic? So we're going to write those along the side here. So the parasympathetic nervous system, we call it the craniosacral division. Why do you think it's called the craniosacral division, looking at this diagram? Yeah, if you look at where these neurons originate, the preganglionic neurons originate in the brain stem, a lot of them. And then if I look at down here in the sacral region of the spinal cord is where I see neurons originate, preganglionic neurons that serve the bladder and the genital area. So the parasympathetic nervous system is called the craniosacral division. And remember when you had to learn the cranial nerves, remember the vagus nerve? Most of the nerves involved in the parasympathetic nervous system run through the vagus nerve. I mean, most of the neurons, run through the vagus nerve. Because look at all the different things that the vagus nerve controls. So if you don't have function of your vagus nerve, if you have damage to the brainstem, you're in trouble. You cannot survive because it controls so many of these important functions. So this here is the vagus nerve. All right, so it's the craniosacral division. What can we say about the length of the preganglionic neuron compared to the length of the postganglionic neuron? Which is longer? Here's the postganglionic neuron out here. The preganglionic neuron is way longer, isn't it? And let's look here. If I look at, well, this one doesn't show it very well, does it? But this is a lot longer in the parasympathetic. Oops. Okay, so very long preganglionic neuron. So where is the ganglia, which is the collection of cell bodies where preganglionic and postganglionic meet? It's very close to the effector organ. Would you agree? Because it's so short. So this ganglia is very close to the effector organ in the parasympathetic nervous system, because it's such a short, very short postganglionic neuron. What else can we say as far as myelination? In both, we can see that the preganglionic neuron is myelinated, but the postganglionic neuron is not myelinated. So that slows the transmission to stimulate these effector organs. So in both divisions, so I would write it on this slide, both divisions we can see that the preganglionic neurons are myelinated. Oops. Okay, So those are some basic things we can gather from the sympathetic nervous system, just generalizations. And then the sympathetic nervous system, what can we say about the preganglionic neuron? It's much shorter. And the ganglia lie very close to the spinal cord. Can you see that? And some of these neurons we can see pass right through the ganglia and go straight out to the effector organ. So there's exceptions to this. But especially in the thoracic region, the upper part of the thoracic region, we can see they end there, and then the postganglionic neuron kicks in or begins. So the one exception where we don't have a postganglionic neuron is going to the adrenal gland. So in the sympathetic nervous system, there's one exception where there's no postganglionic neuron, and that's in the adrenal gland. Remember when we talked about ways that we can get hormones to be released? We said most of it is hormonal, that another hormone acts on an endocrine gland telling it to release its hormone to the blood. And then we talked about neural control was an exception to that rule, that in this case we have a sympathetic neuron stimulating the adrenal medulla to release epinephrine to the blood. So this is an example of neural control of hormone release. So there is no postganglionic neuron in this case. All right, other examples we can see here. What can we say about the postganglionic neuron as far as length? Typically longer than the preganglionic neuron. Yes, definitely. I want to go back to here. Did I tell you this wrong? This is the parasympathetic down here. Did I say that? Yeah. Okay. All right. So this what would we call this then? Looking at where it comes off, where do all these neurons for the sympathetic come off? Yep, thoracic, lumbar region, nothing in the sacral. So we call it the thoracolumbar division. Thoracolumbar division. And these ganglia lie in a chain. So this is the only division, the sympathetic, that has a chain of ganglia that lie right alongside the spinal cord. So this is an example of, let's say a person has an injury in the spinal cord at this level. Okay, so we have information control. If you have an injury to this region of the spinal cord in the lower back, so you broke your back in an accident and damaged the spinal cord, so you would be what type of pelegic if you break? Paraplegic, right? So you're paralyzed from the waist down. So if you have injury here, can you empty your bladder? No, because there's no control of the bladder. There's no lower motor neuron. And that's a somatic thing, right? But is there impulse coming from the bladder into the spinal cord? Yes, there is. And there are autonomic reflexes where we have information coming into the bladder and going right back out to the bladder, called the micturition reflex, which we'll talk about in the urinary system. So we have inputs coming in and going back out at the level of the bladder, but there's no control to empty the bladder. They can be, but if we can't relax that external urethra, which is under voluntary control, you can't empty your bladder. And so we talked about, I think last time, that you have to self-catheterize to empty that bladder. Yes? Yeah, it's not a neuron. It's not a neuron. It's just a connecting point. Yeah, it's the chain, but it's not a neuron that goes down. What we find, though, is some neurons pass through the ganglia and go down this way. So that's what this is showing, is that there is this chain, but not all neurons synapse there. Some pass right through and go down. Some go to the ganglia and go down this way and come out that way. So not every neuron synapses within the ganglia.
So it just passes through the ganglia and then it has a little line on the top.
Yes, that's the end of the neuron. Yeah. And I'm not going to expect you to know the difference, which ones pass through, which ones don't. So don't get worried about that. Just know that in general we see a short preganglionic and a long postganglionic neuron on the sympathetic side. But if we look at, for example, the eye, does the eye have sympathetic neurons and parasympathetic neurons? Yes. And if we look at the skin, does the skin have sympathetic neurons and parasympathetic neurons? No. So if you sweat or form goosebumps, what's controlling that? Sympathetic neurons only. Let's look at another example. Is it not shown on here? Oh, it's not shown in here. Blood vessels are another example. The smooth muscle inside your blood vessels is under sympathetic control. Yeah, it would dilate the blood vessels in the skin. Yep. And also when we, blood pressure control is a sympathetic. Yeah. But we'll get to that. So we'll talk about parasympathetic division. So the parasympathetic division, this is shown in your textbook on page 528. So we can see, again, it's the craniosacral division. Some of them are controlled by cranial nerves here, some of the organs by the cranial nerves. And here's the vagus nerve that controls a majority. So again, we're looking at preganglionic, postganglionic. But the vagus nerve, we can't underemphasize the importance of the vagus nerve. If I stimulate the vagus nerve, it's going to stimulate rest and digest activities, which would do what to the heart? Slow it down, right? So there's a maneuver called the Valsalva maneuver where you ask someone to bear down like they're having a bowel movement, or a woman when she's pushing a baby out, she's going to bear down. That's the Valsalva maneuver. Or even coughing is a really brief example of the Valsalva maneuver. The bearing down stimulates the vagus nerve, which would make sense because when a person bears down to have a bowel movement, that's actually a reflex. And it's amazing that A and P you can see happen naturally in your children. Just observe a baby, from birth through 4 years old, you can just see the action of the parasympathetic nervous system. Right, yeah. They lose a little bit of urine, right? Yeah, and that's increasing pressure. But when a person bears down, it slows the heart rate. And that's okay if someone is actually having a racing heart rate, they're in what we call supraventricular tachycardia, you can tell them to cough. And we've seen it on the monitors, it comes right down. One little cough and that heart rate jumps right back down to normal levels.
That's true when you say that
Mm-hmm. Yep. Because some people, now the heart attack could be caused by a blood clot, but that can also lead to deadly arrhythmias at the same time. So yes, coughing can get your heart out of a bad rhythm. And that's happened to me sometimes when I'm not in great shape and I'm exercising really heavy, like I was playing basketball a couple years ago and was not in good shape. And all of a sudden my heart, when I went out, subbed out, all of a sudden my heart was just beating really fast, like unusually fast, like fluttering, not like a heavy heartbeat with exercise. And it just took one big cough and it took care of it right away. So it's a good thing to tell people that have a high heart rate that's kind of out of control to cough or bear down. But now on the other sense, if someone has really low heart rate because of a failing heart and low blood pressure, and they're constipated and they're sitting on the toilet and bearing down, what can happen? They can definitely pass out, and it happens. There's been situations where people have been ready to discharge or sitting on the toilet trying to have that bowel movement so they can discharge, passed out on the toilet, hit their head on the sink and died. I know a specific story that happened. So very, very important that we recognize the vagal response and either promote it, depending on the situation, or prevent it. So that's where, giving a stool softener or a suppository to help a person have a bowel movement is actually high-end nursing. We don't think it is, but if the reason behind it is because your patient has low heart rate, low blood pressure, and they're constipated, that's going to prevent any issues with bearing down. Okay, so we can see that the organs, the bladder, the ovary, or the reproductive tract of the female and the male are both controlled by the parasympathetic nervous system. So arousal of The reproductive organs, external reproductive organs, and contraction of the uterus are parasympathetic responses. So when a person bears down to have baby, that's going to promote smooth muscle contraction in that uterus and help propel baby out. So as far as a list of what the actions are on each of these organs, that I would recommend that you look at table 14.4 in your textbook. Know the general actions of the parasympathetic nervous system on these organs. I'm not going to go through them in detail, but briefly we've talked about how it constricts the eye. And for the salivary glands, when the parasympathetic nervous system is dominating, we have a watery, high volume saliva. So if you're thinking about food, talking about food, smelling food causes your mouth to water, that's part of the parasympathetic nervous system. So, I don't want to get ahead of myself, I'll stop there. So I'm going to go through the list and just have a general idea of what the actions are on each of these organs. So the sympathetic nervous system, again, we have this chain of ganglia, and we see the receptors of the skin here. So sweating and goosebumps are actions of the sympathetic nervous system only. So in most cases, our organs have dual innervation, which means we have sympathetic neurons feeding them, our parasympathetic nervous neurons feeding them, and we have sympathetic neurons feeding them. So it just depends what division is stimulated depending on the conditions of the body and what sensory information is coming in, right? So if you're relaxed, that's based on information coming in from around you that promotes relaxation. And also, we can control that as well. You can be in a stressful environment and kind of suppress all that information coming in from getting you upset and stimulating the sympathetic nervous system. Where other people can't handle noisy kids and lots of people coming and going. Other people, they can take a nap in the middle of that chaos, right? So that's where our higher brain can control that. So now we get into this very detailed subject of receptors. So there are receptors on neurons and effectors that bind specific neurotransmitters. So the two neurotransmitters that you really need to pay attention to, these are chemicals released from where? Where are neurotransmitters released? If we go back to this very basic diagram. Where do we release neurotransmitters? Think about it for a minute. Where do we make the neurotransmitter, first of all? Here's a cell. We're making a neurotransmitter. Where do we make it? To make it, most neurotransmitters are proteins or amines. So therefore, where do we make proteins and amines? Yeah, ribosomes, Ruffy-Yar, Golgi apparatus. Where are all those organelles located? In the cell body. Okay, very good. This is where we're down in the trees right now. We're forgetting the forest. So the zooming out, right, in the cell body is where these neurotransmitters are made. And then they're stored where? Axon terminals in little tiny membranes called vesicles. Yeah, so that's all that old information from General A&P, and we did review that this semester too. So they're stored in vesicles in the axon terminals, and they're stimulated to be released when? We talked about this semester. What? Yeah, when calcium goes into the cell, what type of channels open up to allow calcium in? Voltage-gated channels, right. So what stimulates, what has to come down the axon terminal to stimulate those voltage-gated calcium channels to open? Action potential. So we have to stimulate an action potential in this preganglionic neuron to release these neurotransmitters into the synapse. And what type of channels do I need to have on this postganglionic neuron? Chemically gated channels that are specific to this neurotransmitter to allow sodium in, bring it down this neuron to release its neurotransmitter from the axon terminals here. So if you look in your textbook on page 526, we can name these. These triangular ones are acetylcholine. So anywhere you see blue triangles, you can put acetylcholine. ACH is the abbreviation for that. So acetylcholine is released from all somatic motor neurons, the lower motor neurons, all of them secrete acetylcholine. And you've seen that in the neuromuscular junction. Acetylcholine is released, sodium channels open, we get an action potential to contract that skeletal muscle. Would you agree with me that acetylcholine is released from all preganglionic neurons, sympathetic and parasympathetic, based on what we see here? Yeah. So would you expect that to stimulate or inhibit the second one in the row? Stimulate, yeah. These are all going to be excitatory here. But in the postganglionic neuron, especially in this one, sympathetic neuron, is that going to always stimulate digestive tract motility and smooth muscle contraction? No. So this might stimulate or inhibit, depending. And this is not acetylcholine, right? This is our other neurotransmitter, which is norepinephrine, which we can abbreviate capital N, capital E. So here we have acetylcholine stimulating the adrenal medulla cells to release what to the blood? Norepinephrine. So does it make sense that the sympathetic nervous system, and norepinephrine is, another name for it is adrenaline. And when you think about adrenaline, don't you think about revving up, right? So this is all, right. So this is, well, not always excitatory though. It depends what it binds to. Right. Exactly, exactly, because it's going to inhibit smooth muscle contraction. It's going to inhibit bladder contraction, smooth muscle contraction, release of certain hormones. Okay, so this is norepinephrine, NE here, and that's, would you agree that norepinephrine is specific to the sympathetic nervous system? Definitely. And that's why I made this particular PowerPoint all visual, because there's a lot of information here again. Rather than putting this on 50 PowerPoint slides and textual information, just study this, and there's so much information here. Okay, so then if we look at the parasympathetic nervous system, what does that postganglionic neuron release? Acetylcholine, only. Now, can that stimulate or inhibit? What would it stimulate? Well, it's not showing anything. It's going to this whole cluster of things. So what would the parasympathetic actually stimulate of these organs? Which means increase its activity. Digestion. So which organs would contract and be excited from ACH via parasympathetic neurons? Stomach, small and large intestine, right? Do people, you know, when they go to the bathroom to have a bowel movement, don't they take the newspaper in there or a book and relax, right? So you're stimulating, by doing that relaxation, you are stimulating the parasympathetic neurons to release acetylcholine to excite the cells that line the muscle cells of these digestive organs to contract. But what is it doing to the heart? Inhibiting the heart muscle cells from contracting. Okay, so those are the two major neurotransmitters, and you should know where they're released. So they're released from all somatic motor neurons. They're released from all, in terms of acetylcholine released from all somatic neurons, all preganglionic autonomic neurons, and only parasympathetic postganglionic. So we'll pick up next time talking about different types of receptors, nicotinic, muscarinic, adrenergic.